Hello everyone, my name is Sean Streeter. Today's discussion topic will be platelet responses to avatrombopag in chronic immune thrombocytopenia and the clinical implications. I have with me here today Dr. Srikanth Nagalla, an expert in ITP. Dr. Nagalla, would you like to introduce yourself?
I'm Sri Nagalla, and I am the chief of benign hematology or classical hematology at the Miami Cancer Institute. It's part of Baptist Health South Florida. So I primarily do non-malignant blood disorders, and ITP patients are something I treat on a daily basis, and we see a lot of ITP patients in our practice.
Thank you for being here with us today, Dr. Nagalla. So before we dive into the data, would you like to tell us a little bit about immune thrombocytopenia and the study treatment?
Absolutely. So immune thrombocytopenia, for short, it stands for ITP. In the past, we used to call it idiopathic thrombocytopenic purpura, but now the new terminology is immune thrombocytopenia because not everybody has purpura and it's not idiopathic. We know that it's immune mediated. So this is an acquired autoimmune disorder, and the platelet count should be less than 100,000 without any other causes of thrombocytopenia. And it could be because of accelerated rate of destruction, and there could be a degree of underproduction also. So it's in some patients, it's one of the other mechanism or the second mechanism, but a lot of times it's both the things happening together. And severe ITP is defined as a platelet count less than 50,000.
And for the study treatment, what does that involve?
The study treatment we looked at is avatrombopag, and it is an oral thrombopoietin receptor agonist, otherwise called as a thrombopoietin mimetic. So it mimics the thrombopoietin. It works on the thrombopoietin receptor. It doesn't compete with the endogenous thrombopoietin, but it complements the body's own platelet production with the native thrombopoietin.
Got it. So now that we have a little bit of context, would you mind giving us a brief overview of the design of the study for the phase 3 trial for avatrombopag?
Absolutely. So this study is a double-blind, placebo-controlled, and it was done for 6 months. Patients had the initial course study, and who completed that or who had a suboptimal efficacy could enter the extension phase for a further 36 weeks. So there were 32 patients who were enrolled on the avatrombopag arm in the core study and 17 on the placebo. The avatrombopag patients started on 20 milligrams daily, and then the dose was titrated because the goal was to keep the platelet count between 50,000 and 150,000. So you titrated the dose of avatrombopag with anywhere between 5 milligrams to 40 milligrams. The primary endpoint was the cumulative number of weeks of platelet response, and that was defined by a platelet count greater than 50,000 in the absence of rescue therapy for over 6 months. So that's the primary endpoint. The key secondary endpoint was the proportion of patients achieving a platelet count greater than or equal to 50,000 by day 8 of the study. Okay. And then there was an exploratory endpoint, which is a durable platelet response rate, defined as a proportion of patients who had a platelet response for greater than or equal to 6 of the last 8 weeks of treatment.
So quite a few endpoints there, Dr. Nagalla. What do these endpoints and what do these platelet thresholds mean for the patient?
So as per the ASH 2019 and ICR guidelines, a platelet count greater than or equal to 50,000 is a common goal for platelet response in both these studies and even in clinical practice. Why is this 50,000? Because that's the number at which we could do a lot of procedures, and that's the number at which people think that it's hemostatic. And there might be instances where you want a higher number, but 50,000 is considered a safe number for a patient to get common procedures and other things. And then a number greater than 100,000 is considered a complete response. So we examined both these endpoints in both the core study and its extension phase.
Right. Thank you for that overview. So what were the study findings?
Okay. So I told you a number of endpoints, so let's just go over one at a time. So the primary endpoint, if you take that, the avatrombopag was shown to be superior to placebo in cumulative number of weeks of platelet response. So what does that mean? There was a significantly longer duration of a platelet count greater than or equal to 50,000 in the absence of rescue therapy, like rescue therapies or like steroids or IVIG, intravenous immunoglobulins. So in the absence of those, with avatrombopag than with the placebo. I'll call avatrombopag short as AVA so that it's easy for everyone to follow along. So the median was for 12.4 for the AVA group, and then it was 0 weeks now for the placebo group, and the mean was 12 versus 0.1 weeks. And then if you go to this key secondary endpoint, 66% of the patients in the AVA group reached a platelet count greater than or equal to 50,000 by day 8. And then the mean platelet count among these patients was greater than 80,000. And over half of these patients had a complete response. So I told you the complete response is that 100,000 number, and no placebo patients achieved this endpoint. Now, when we came to the durable platelet response rate, it was significantly again greater with AVA compared to those receiving placebo. It was 34.4% for the AVA group and then 0% for the placebo group. 84% of the AVA patients achieved a platelet response, and the platelet response, we're defining it as greater than or equal to 50,000. And relative to the placebo patients, by day 28, so by 4 weeks, 84% of them were able to get to that mark. And by 6 months, it was 88%. So they were able to keep that at 6 months. A complete response where, again, it was not the 50,000, now it's much higher. The 100,000 was achieved by 81% of the AVA patients at any time during the first 6 months of the core study.
Got it. So based on these study findings, they seem to suggest that many patients within 8 days achieve a platelet response. Is this rapid response a common goal in clinical practice?
A treating physician may be more interested in maintaining a strong and durable platelet count, but a rapid response is still important because the patient is anxious and they want to make sure that they're responding to their treatments. And it's also important for the physician also. Let's say the patient is not responding to steroids and IVIG, the intravenous immunoglobulin, and they're in single-digit platelet numbers. The patient wants to make sure that he or she doesn't bleed, and the physician also is interested in that. So getting the platelet count up faster. So by day 8, if you can do it, that's almost a week. So in this study, a significantly greater portion of patients with AVA group achieved a durable response. That's like 34% of them versus 0 in the placebo. And 87% or 87.5% of AVA patients achieved a platelet count of greater than 50,000 in the first 6 months compared to the 5.9% in the placebo group. And furthermore, 81.3% or so, like 81% of AVA patients achieved a complete response at least once, meaning that 100,000 mark, at least once during the first 6 months of the core study, compared with 5.9% of the placebo group. And over the first 6 months, the mean platelet count increased from 14,000 at baseline, which is kind of a low number in day-to-day life, and then to 63,000, so above that 50,000 mark.
Wow. So I know earlier we talked a little bit about the extension phase of the studies. What were the findings there?
So eligible patients who received placebo in the core study switched to AVA treatment in the extension phase. And the integrated analysis found that 94% of the initial AVA patients and 65% of the initial placebo patients who then went on to receive AVA achieved a count greater than or equal to 50,000 at any time during the study period. That is, combining the core with the extension parts of the study. Around 84% or so of the initial avatrombopag patients and about 58 to 59% of the initial placebo patients achieved a complete response during the entire study period when you combine both the phases. Yeah.
So to wrap everything together, based on your clinical experience, how do the results of the extension phase and the core phase translate into clinical practice?
So the study data necessarily rely on quantifiable endpoints such as platelet counts. So while treating physicians, of course, monitor these outcomes, it is important to remember that every patient has their own expectations and treatment goals. So, for example, there are patients that we see in practice who may not be responding to steroids, may not be responding to IVIG, and their platelet numbers are in single digits. Now, these patients could be at risk of bleeding, and we have had patients who didn't respond to these medications. Now, patients like this, when your usual medications that get the platelet count up fast, which is like intravenous immunoglobulin or steroids, don't work, you need to reach out to agents like the thrombopoietin receptor agonists or the thrombopoietin mimetics. So we saw the thrombopoietin receptor agonist, avatrombopag, was able to get the patient's platelet counts in the study up by day 8. But patients go for procedures and surgeries, and they have different goals in terms of their platelet numbers and everything. And agents like the avatrombopag, as we could see, we could titrate the dose so that you can get to a number that is needed for that particular patient within the range that we were talking earlier. And patients respond differently, and this is because of multiple complexities and multiple factors that are responsible for their ITP and other patient factors and environmental factors.
Yeah, so Dr. Nagalla, we appreciate your clinical expertise today. Are there any other take-home messages or points of emphasis you have for our audience today?
No, I think we covered everything. So this is a disease which could be, severe, like it's very life-threatening in the sense that a lot of our audience, like the physicians, they are hematologists and oncologists. They're practicing cancer, they're practicing both blood disorders, which is a very difficult job because they have to be up to date with everything. And even when they are seeing their really malignant patients in terms of metastatic cancers like pancreatic cancer, the usual life expectancy in these situations could be months or weeks. But in a disease like ITP, if it's very severe, you could have life-threatening complications that could cause really bad outcomes even in a day or two. So this is a disease where we have to use our treatments which we have, which could be effectively helping them to reach a platelet goal much faster, let's say by day 8 or even earlier than that, and keep a sustained and a durable response so that this prevents the patients from bleeding or having a bleeding complication.
Great. And so, Dr. Nagalla, thank you for your time again. It was a pleasure having you.
Yeah, thank you.
Doptelet, avatrombopag, is indicated in adult patients with chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. Before taking Doptelet, tell your healthcare provider about all your medical conditions, including if you ever had a blood clot, are pregnant, or plan to become pregnant. Doptelet may harm your unborn baby. Tell your healthcare provider if you become pregnant or think you may be pregnant during the treatment with Doptelet. Also tell your doctor if you are breastfeeding or plan to breastfeed. It is not known if Doptelet passes on to your breast milk. Do not breastfeed during treatment with Doptelet and for at least 2 weeks after the last dose. Talk to your healthcare provider about the best way to feed your baby during this time. Tell your healthcare provider about all the medicines that you take, including prescription and over-the-counter medications, vitamins, herbal supplements. Doptelet may affect the way other medications work, and other medications may also affect the way Doptelet works. TPO receptor agonists have been associated with thromboembolic complications in patients with chronic ITP. Thromboembolic events, atrial and venous, have been reported in patients with chronic ITP treated with TPO receptor agonists. Consider the potential increase in thrombotic risk when administering Doptelet to patients with known risk factors for thromboembolism, including genetic prothrombotic conditions and acquired risk factors. Monitor platelet counts for signs and symptoms of thromboembolic events, and institute treatment promptly. Serious adverse reactions that have occurred more frequently in patients treated with Doptelet compared to placebo was headache. The most common adverse reactions, occurring in 10% or more of patients with chronic ITP, were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis.